je vais parler des modes de prévention, de traitement pour les populations d'utilisateurs de drogue. Et puis, je vais être suivi par Daniel Zulaka, qui est responsable du programme de VIH pour la région de Basque, suivi par Laurence Weiss, qui est avec le Centre hospitalier Georges Pompidou et l'Université de Paris-Descartes, qui va nous parler de morbidité et de mortalité. OK, mes slides sont là. Maintenant, je vais passer à l'anglais, parce que c'est beaucoup plus facile pour moi en anglais que en français. OK, my main objective this morning is to try to briefly go over some of the basic epidemiological characteristics of the HIV/AIDS epidemic, and I'll cover some global issues, and then I'll go into some national data. It will be very brief, just to give some background. Then I'll go over reviewing some of the main prevention interventions that have been found to be effective, and followed by making recommendations for what should the next steps be to further reduce transmission rates among that high-risk populations of drug users. And I also would like to bring your attention to some recent NIDA initiatives that you may be interested in considering applying for. Injection drug use has been reported in about 148 countries, and it is estimated that there's about 16 million people that are injecting worldwide. The countries with the largest numbers, which you very well probably already know about, is China, followed by the US and Russia. And the prevalence rates vary quite a bit across different countries. There's about 5 countries that have rates that are over 40% in prevalence. And they estimate that there's about 3 million people that are injection drug users that are infected across the world. There has been a phenomena in Africa, sub-Saharan Africa. The increase of heroin use has drastically been increasing in the last few years, especially in South Africa, Kenya, Tanzania, and some other countries. And we're seeing increases in methamphetamine use, stimulants in South Africa. So we're paying a lot of attention to that phenomena to make sure that we're going to try to provide ways to try to limit the spread of HIV-related drug use in those areas. Domestically, in the U.S., it's a very dynamic epidemic. If you look at incidence rates across the last 20 years or so, it's varied, lines crisscross, which means there's a lot of things that change over time. One thing that you will notice that early on, from day one and even today, men who have sex with men have always been and will continue to be the #1 transmission route in the U.S. It's like that in many parts of the world, including Western Europe and South America as well. The one thing that is worth noting is the substantial reduction that we've seen in injection drug use over the years. If you look, whoa, I pressed the button, wrong button. Well, if you look at the dark blue line, that's dotted line, you see that between 88 and 91, 93, there has been substantial drops in incidence in injection drug use. I'll summarize the data in a few seconds. This is showing new cases of AIDS. The major drop in 93 or so was due mainly to a change in definition of AIDS, but following that was the introduction. A lot of the reductions were attributed to the reductions due to antiretroviral therapy starting in 96 and up. But there too, you will see that the pink line, which is heterosexual, and the blue line crisscross. At one point, injection drug use was #2 in the US, and it started dropping, and heterosexual took over in terms of new cases of AIDS. One important thing that our institute tries to get across is that when we talk about the relationship between drug abuse and HIV or AIDS, a lot of people think of injection drug use, but there's more to it than that. If you look at prevalence among non-injection drug use and you compare it to injection drug use in some cities across the world, they are very, very close. And that phenomena is increasing in the U.S. drastically because of the fact that we've reduced transmission in IDU substantially. We have programs that have tried to get people to look at the issue of non-injection drug use and HIV. We have been to some extent successful, mainly with the MSM using methamphetamine, but we haven't been that successful with minority African-American MSMs and use of stimulants. The pattern of drug use is quite different between majority members, Caucasians, and African-Americans. The African-Americans predominantly use cocaine as their drug of choice, whereas Caucasians were the ones using predominantly methamphetamine as a stimulant. But that is also starting to change. There's more and more African-Americans that are starting to use methamphetamine in the U.S. The decrease in incidence rate that I was referring to is 80% between 1988, the period of 1988 to 1990, and the period of 2003 to 2006. We saw between those two periods an 80% drop in incidence rate among injection drug use. Today in the U.S., there's about 50,000 new incident cases a year. It has been that for since 2010 or so, since the turn of the century. It varies, with some years being like 54, 56, some being 48, but the average is it's gravitating around about 50,000 new cases a year. 2/3 of the new cases are due to men who have sex with men, and 27% of the new cases are due to heterosexual transmission, and only 9% of the new cases are due to injection drug use. It used to be in the low 30s for injection drug use in terms of new cases, and now it's down to 9% or so. There is also one noting phenomena. There's huge health disparities in infection rates in the United States. For example, African-American population represents 14% of the entire U.S. population, and they have 44% of the new incident cases in the U.S. So the disparities are humongous. There's not as severe disparities for Latinos, but there is substantial differences in their representation in the population and their proportion of Latinos that are infected by HIV as well. The worst group, the only group actually that we observed in an increase in incidence in the last few years has been the young African-American MSM. Their rate has increased by 48% in the last few years, so it's humongous. As a matter of fact, one of the prime priorities of the National AIDS Strategy from the White House is to target young African-American MSM to try to address the outrageously high incidence rate. The last bullet on this slide also reflects the magnitude of use of methamphetamine among men who have sex with men, which is 22.5 times higher than in the general population, and their rate of infection is 40 times higher than the general population. Now I'm going to just try to give you an overview of some of the key prevention interventions that have been found over the years to be effective for addressing the issue of HIV in drug-using populations, and then make recommendations, as I said earlier, for what should we do next. The one that got a lot of controversy over the years, as you well know, is needle exchange programs. That has been challenged over the years. The government started issuing reports, evaluation reports, back in 1993. There was a GAO report that was issued, and that was shortly thereafter followed by a CDC, University of California, San Francisco report. The Congress dismissed to some extent those reports as being government reports that are censored by government, so they wanted an independent organization to take a look at it. So they asked the Institute of Medicine, as part of the National Academy of Science, to take a look at the needle exchange as being an effective or not modality for reducing transmission. That was followed by an NIH consensus statement, which is also a similar process. They bring external people that are not government employees to take a look at the science and make recommendations that are blessed by the NIH. Following those reports, the Secretary of Health, the Minister of Health at that time in the U.S., was Donna Shalala, and she made a public statement in '98 that needle exchange, when it's part of a comprehensive HIV strategy, can prevent HIV transmission. That was a major position on the part of the U.S. government, but they did not provide any U.S. funds or government funds to finance needle exchange programs. That came about only about 2-3 years ago when Congress allowed people to apply for U.S. government funds to subsidize the needle exchange, but they did not appropriate additional funds. They had to use funds they already were receiving, which meant cutting other programs to actually be able to support needle exchange. Outreach was, in the early years of the epidemic, the first strategy that was employed to actually reach the injection drug users and also educate them about risk behaviors and provide them with means for reducing their risk. There's been quite a few reviews on it. One of the ones was in 1998, Susan Coyle had a review in the Public Health Report Journal, which summarized all of the literature at that time on it. And it came down to it's very effective in reducing injection risk, but it doesn't do much to reduce sexual risk. Sexual risk is a lot more difficult to reduce than injection drug use risk. As far as drug treatment as an HIV prevention modality, the seminal paper came out back in '93. David Metzger, who's been here before, I think it was here 2 years ago, had a study that he compared people that are in treatment or people that are partially accessing drug treatment and those that are out of treatment, and compared the rates of incidence, seroconversions in those three groups, and reported drastic differences showing that drug treatment had substantial protective effects. The literature on drug treatment has looked at opiate substitution therapy, and also there's quite a bit on naltrexone and different delivery modalities, showing that it reduces drug risk and that it also reduces, to some extent but less, sexual risk behaviors. And there's a few key articles there that actually report on that. Stimulant use, as it was mentioned in the last few days here, is a different story. There's no pharmacotherapy for stimulant use, be it cocaine or methamphetamine. And most of the interventions are behavioral interventions. We have been successful. A lot of people, the UCLA group has done a lot with MSM Latinos and looking at HIV transmission by providing various types of interventions, behavioral intervention, and they also have shown reduction in risk behavior, including decreasing the number of partners, sexual partners, concurrent partners. WHO has also made statements and done studies showing that that drug treatment is also effective in reducing risk behaviors in middle-income countries, which are quite different cultural and environmentally than the Western world, where all these studies have been done. The drug abuse in art, there is substantial literature showing that opiate substitution therapy does help suppress viral load, and that people that are in treatment have lower viral load than people that are not in treatment. It also has shown that there is an impact on adherence and also reducing the viral load in some of that literature. And it also brings in, like the Thomas Kerr yesterday was mentioning, that initiation to drug treatment also helps the getting people on art therapy. A lot of drug-using population are reluctant to start using art, especially if there's no symptoms. If they're asymptomatic, they are not willing or understanding why they should get on art therapy as early as possible. The other area which you've heard about 2 years ago when Julio Montaner was here, has to do with using art therapy as HIV prevention. One of the key articles from Julio's group came out in Lancet in 2006, where he lays out the rationale for why it as credibility for being an effective intervention, that not only does it have benefit for the individual, that is on heart in terms of morbidity and mortality, but it also will bear on population transmission rates. And there has been to date a few studies that have looked at the reduction in incidence rate. A lot of studies have looked at reductions in newly diagnosed cases, which is quite a bit controversial because some researchers don't like using as an endpoint newly diagnosed HIV cases and equate that with incidence. But there has been data on both the incidence and I'll show you some of the data, the main data that's been reported in the literature. The first study showing that expansion of art therapy as a bearing on reducing incidence rate was done in Taiwan when they made art therapy available to the general public for free, and they reported reductions in incidence of 53% or so. That was a 2004 article. The other incident paper was from Julio's group, where they looked at community viral load in blue and showed, which was the median viral load in the targeted population, and showed that it was associated with a reduction in incidence over the years from between 96 and 2004. Julio's group also reported on newly diagnosed cases for a longer period of time, showing that the scaling up of making art therapy available was associated with a reduction in newly diagnosed cases in the population, and also in the green dotted line there in injection drug using population. Following these reports, there's been reports in San Francisco by Grant Koufax groups looking at community viral load and looking at relationships between newly diagnosed and incident cases. And here the bars in blue show the community viral load, and the red triangle shows the incident cases, reductions in incident cases, and the square or rectangular red boxes show the reduction in newly diagnosed case that parallels the incidence pretty well. The last data showing the relationship between community viral load and reduction in incidence comes out of the Baltimore Johns Hopkins group, the ALIVE cohort, showing again that if you expand coverage of art therapy, that you will observe reductions in incident cases, which are the dots that are at the bottom of the graph there. This study was reported at CROI last year. In Boston, I think it was, yeah. And the paper is in press. I mean, it's been submitted. It's not been accepted yet, but it's been submitted for publication, and it should be coming out soon. What's interesting about this paper is that before HART was available, before '96, the reduction that was being observed in incidence cases was attributable to reduction in risk behaviors, injection risk behaviors. Following HART, once the control for reduction in injection risk behaviors, you still observe a reduction attributable to the expansion of HART. So it was not, the reduction in post-96 was not exclusively attributable to the reduction in risk behaviors for injection. They do look at that issue in the paper that they've submitted. Recent initiatives on treatment as prevention. NIDA has invested a substantial amount of money into art therapy as HIV prevention. We first focused on the criminal justice population. There's about a third of the population that are HIV infected that will rotate through the criminal justice, some component of the criminal justice in the United States, be it jails, prisons, juvenile criminal system, or probation, or parole. So a big proportion of HIV positive are going to that system, so we felt it would be a good opportunity to try to diagnose those that are infected and get them on art therapy and try to retain them on art therapy. So we invested $10 million a year for 5 years, which is $50 million over the course of 5 years, to look at that issue of seek, test, and treat within the communities, the criminal justice system. The next year we followed that with another RFA that was trying to target vulnerable populations for implementing Seek, Test, and Treat, and we contributed $8 million a year, which is another $40 million over the course of 5 years. The issue of Seek, Test, and Treat is going to still remain a high priority of NIDA. We are encouraging people to come in with applications looking at any of the components, be it seeking and testing, or be it testing and linking to treatment, or linking to treatment and trying to retain them in treatment and make sure they're adhering to their ART regime treatment protocols. So it's not because we're not going to be issuing another RFA that we're not interested in it. We are very interested in getting new applications from investigators on that topic. One of the primary proof of concepts was what we call the HPTN 052. HPTN stands for HIV Prevention Trial Network. It's a major network that's part of NIAID, the National Institute on Allergies and Infectious Disease at NIH. And NIDA and about 3 other institutes at NIH contribute funds to that network. And Myron Cohen from North Carolina reported the findings of the HPTN 052 at the Rome meeting in July, which shows that if you do provide ART, that you substantially reduce the effectiveness of transmitting HIV to a seronegative partner. They looked at serodiscordant couples, and they showed that ART therapy was protective at 96% from preventing transmission. Prior to that study, and that's in heterosexual discordant couples, prior to that study, the proof of concept for ART as prevention relied mainly on vertical transmission, mother-to-child transmission, showing ART does prevent transmission from one person to another, from one positive to a negative person. So that was a major landmark study that was published in New England Journal of Medicine in July, mid-July. If you look at the list of proven effective intervention programs, it's quite extensive. Some of them are more specific for drug-using population. Some are applicable to general population. They include drug treatment as HIV prevention, like I mentioned, ART as HIV prevention, community-based outreach, syringe exchange, sexual risk reduction, condom distribution programs, supervised injection room, which you've heard about yesterday by Thomas. Then you have the big issue of PrEP and microbicides and PEP, meaning pre-exposure prophylaxis, and microbicides and post-exposure prophylaxis. The PrEP studies, just over a year ago, they had an MSM study showing efficacy for PrEP, and recently, around just early July, there were reports on 2 trials in Africa for heterosexual couples showing that pre-exposure prophylaxis was effective. There's a CDC trial underway that's coming close to being done for IDU, injection drug users, looking at PrEP. The results should be out within the next 6 months or so. The design of that PrEP study is some concern because they're targeting injection drug users that are in treatment, and even the control arm is getting tremendous HIV prevention exposure. So the ability of the trial to be able to show a difference is going to be difficult because they're already not the higher risk injectors. They're those that are enrolled in drug treatment, and also the fact that the control arm is getting an extensive treatment as usual prevention intervention. Male circumcision has been shown to be very effective in a major trial, 60% reduction, prevention and treatment of STIs and mother-child. The question becomes, how do you go about combining these things? And that's a new area, not new area, it's an area that's been getting a lot of attention in the US about what's the best way to pick and choose. The reason being that everyone agrees that there's not one of these interventions that will do the trick, that you have to try to find the best way of combining these to have optimum effects. But how do you go about doing that is the question of interest. What has been coming out in the literature or in the policy decision-making circles of Washington and NIH is that we definitely need to do some formal assessment, and implementation science is what's going to allow us to answer those questions. It's basically taking shown to be effective interventions and transporting them into different cultures, given cultural, legal, structural hurdles or constraints that you have to be aware of. How do you go about picking which ones are the best? One controversy also that arises when one intervention is shown to be very effective is that people get very defensive and worried that, well, all the money is going to go to seek, test, and treat, and they're not going to put any money in other modalities of prevention. So it's a good thing that people are realizing that it's not just one, but it's a matter of trying to actually find the best combination. As a result of that, there has been various major initiatives launched to try to generate applications, to try to start doing research using the huge PEPFAR platform. They are all over the world, most of the places in the world, either directly or indirectly to USAID or CDC, but a lot of their money is going in a lot of countries to either distribute and make art therapy available and implement prevention programs. And what NIH and other research agencies in the US have done is try to collaborate with PEPFAR to use their infrastructure to actually do the research to see how you go about identifying what component works best. The NIDA PEPFAR collaboration I'll get into in a few minutes. First, I'll just give you an idea of 3 other interventions that involve PEPFAR collaboration. The first one is NIH and PEPFAR. The other one is USAID and PEPFAR and CDC and PEPFAR. Those 3 interventions total $45 million. Each award is about $15 million, and it's for 4 years. The NIH award was given to the London School of Hygiene and Tropical Medicine, and they're going to be looking at ways to do and implement household-based testing and linking people to treatment through the community treatment providers in 2 sub-Saharan African countries. The USAID award went to Johns Hopkins, and they're going to be looking at biomedical, including PrEP, microbicides, those types, male circumcision, and also behavioral interventions to try to impact incidence rates in Tanzania. And Tanzania, by the way, has a severe heroin injection problem, and there's been introduction of methadone there for the last over a year now. The last one, the CDC program, has been awarded to Harvard, and they're going to be expanding coverage. It's basically doing seek, test, and treat in Botswana in Africa. The NIDA initiative is $4 million a year for 5 years, which means $20 million a year, and we're trying to take, it doesn't necessarily imply combination, but it's implementation science, using a strategy that we know works in Western world. How do you go about implementing that in third world countries or developing countries? The applications, we got 22 applications. We surprisingly got a lot of African applications because NIDA doesn't have a big presence in Africa. We have a presence in Kenya, Tanzania, and South Africa, and we're not in any of the other countries. But for this announcement, we got applications from quite a diverse group of countries in Africa. We have also gotten Eastern Europe with 2 coming from Ukraine and 3 from Russia. Vietnam got the most because it's a primary PEPFAR country, got 5 applications. And then we got Cambodia, China, and Mexico. To date, in terms of what are hot topics, not only at NIDA, but in the world of HIV/AIDS in the US, the primary, I would say, the hottest topic is latent virus reservoir issue, looking at what they call towards a cure, trying to get to the latent virus. That is getting a lot of attention and a lot of funding. There's large awards that are being awarded to various groups that include collaborations between university-based researchers and the pharmaceutical companies to try to do a better job at addressing that. We have some of our PIs that are looking at that issue and how drug abuse bear on that, and they include Rafit Pierre-Sekali, David Margolis, Eric Verdon, and Jonathan Karn. Treatment as HIV prevention, because of 052, is having a big impact on people actually trying to use ART as a prevention modality and seek, test, and treat. PrEP is going to get very controversial because it's actually providing antiretroviral therapy to seronegative people for preventing acquisition, not transmission. And in countries like the United States, we have 10,000 people that are diagnosed, that meet the criteria for getting ART therapy, that cannot get access to ART therapy, and they're on waiting lists, and if they don't get the drug, they're going to die. So it becomes a very difficult strategy to implement PrEP from a public health standpoint using public funds to give medication to people that are not sick when you have people like in countries like the United States that are unable to access ART therapy and they meet the criteria for getting treatment. So it's a good proof of concept, but it's not going to be easy to roll out PrEP. There may be applications where when you have major outbreaks in a very constrained high-risk group where you could flood that community with antiretroviral therapies to prevent an outbreak. But in terms of making that strategy widely available to anyone that qualifies as engaging in some risk behaviors, it's going to have a lot of political connotation down the road. And implementation science is the last hot topic. Tools that would be useful for helping us reduce further the transmission rates among drug-using population include long-lasting pharmacotherapies because of adherence issues. The Vivitrol is getting, naltrexone Vivitrol is the injection form, which is good for a month, is getting a lot of attention and criticism, as Mary Jean addressed 2 days ago. Depot buprenorphine, there's a JAMA article by Walter Ling that came out showing how effective it is, and FDA is considering approving the depot buprenorphine. That should be coming pretty soon. As you know, we have people working on vaccines. You heard Frank Horson yesterday talk about vaccines for illicit drug use. That's a tool that would be also helpful down the road. Again, developing a therapeutic that will cure AIDS is, of course, something that that will help contain that, and also a preventive vaccine for HIV, but I wouldn't hold my breath. Even if we get that, it will not solve the problem. HIV, AIDS is here to stay. The only disease that the biomedical field was ever able to eradicate from the face of the earth is smallpox. We have the means to eradicate an awful lot of disease, but we don't have the will of government to do it. So until we get the governments of the world willing to invest and address HIV, when we get all these tools to actually cure it, prevent it, then we may be able to get rid of it. But I don't see that forthcoming very soon. A few publications I want to make you aware of. We have, and I'll give you the website in 2 or 3 slides from now, where you could get all these publications. We have special issues that were published in JADES, and also a report that was published both in Russian and in English, because we released it in Vienna. That's the reason why we published it in Russian as well as in English. That summarizes all the literature on prevention, treatment, and treatment constraints and interactions of drugs. There's all kinds of issues that are addressed in those publications that may be of interest to some people. Another publicity, I'd like to try to entice you to apply for one of the awards that we give. It's called the Avant-Garde Award. It's a 5-page application, and it's the first year that we're opening it up to international. It's been always open to international applicants, but they had to be affiliated with a U.S. institution, which means you could, like Eric Verden is Belgian, and he works at UCSF. So, but he got it 2 years ago because he has an affiliation with UCSF. So this year is the first year that we're actually opening it to anyone in the world, even if they're not affiliated with an American institution, and they could apply for it. It's a 5-page application. The only requirement is that you have to come up with a very crazy idea that would not normally get funded, but if it works, it would have tremendous public health impact. We're giving $500,000 a year plus the indirect costs, the overhead costs, for 5 years. And we've been doing it for 4 years now. And the mixture of people that have received it include Julio Montagnier that talked here, like I mentioned, Refit Pierre Sekali that's looking at latent virus. This past year, we gave it to David Ho from Rockefeller University. And the webpage that I mentioned is listed right here. Thank you.